This video features two patient stories. The patients shown are undergoing colorectal surgery and being treated according to the enhanced recovery pathway. Their stories are typical of the treatment and outcomes for these procedures, but everyone is different and your treatment and recovery may not be the same. We hope this video will answer some of your questions, but it will also help you to think about questions you may have about your specific circumstances, and you should not hesitate to put your questions to the nursing and surgical team when you see them in the course of your treatment.
It was a shock to know that I did have cancer, because I had no inkling that I was ill at all. So it was quite a shock, but I mean, you just do what they tell you, don't you, and get on with it. They make an appointment for you, go to the hospital and you discuss it with a nurse, and in turn they refer you to the surgeon, or go and have a camera and search your bowel to find out if there is any abnormalities, which in my case there was. Then I had a scan so that they could see if it had gone anywhere else or if there was any other lumps or anything around. And then they found out, well, they took a biopsy, which was obviously tested, and they found it was cancerous.
He had it in the more upstream part of the large bowel, so we were confident that we could join the bowel ends together.
You have to go to see the doctor and the nurse, and they discuss what they're going to do, and then you go on to the next stage where you go in for the hospital, the actual treatment, and then they designate you a nurse, which is mine's Gemma, which will see me through now till I'm quite satisfied that it's all clear.
Yeah, of course. Yeah, absolutely. Let's just be definite.
Yeah, exactly.
Excellent.
We went through the actual process 2 or 3 times. The actual surgeon, towards, before the operation, and I think it was a week before, I go and see him and the nurse, and they go through exactly what they're going to do to you. So
this is the area we're going to be removing, and we're also going to be removing the fat surrounding, which is where these little lymph nodes live. Yeah. Okay.
When they're going to do it, and what the treatment is afterwards. So you're not kept in the dark on any of it, really. My appointment was, to go down to the theatre was 8:15 in the morning, so I had to be there at 7.
Morning, David. My name's Stuart. I'm just going to do your blood pressure, if that's okay.
Whereupon they weigh you and test your heart and whatever.
Monitor your SATs, that's how much red oxygen's in your red blood cells. Just going to press start.
The purpose of my assessment is just to find out about his medical problems, to discuss an anaesthetic plan with him in terms of pain relief, to let him know what will happen afterwards, so he'll go to recovery and then into the high dependency unit, discuss pain relief options with him, and in fact we decided on an epidural would be best for him, and then gave him the opportunity to ask any questions he might have about the whole process.
I went into the theatre about 8:15, 8:20, and I don't really remember anything till about 3 o'clock in the afternoon.
And then at that point, I go off to the theatre, essentially get all his anaesthetic ready with my assistant.
Morning, Mr. Hughes.
Hello.
How are you, sir? You all right?
Yes, sir.
My name's Lee. I'm another part of the anaesthetic team, sir, and I'm
Right.
just going to repeat the questions that Charlotte asked you about 10 seconds ago.
Right, okay.
Please may I check your wristband?
And then we send for him. He then comes round to theatre, we check his consent once more to ensure it's the right patient for the right operation. And then we get on with the anaesthetic proper.
So what I'm going to do, sir, is just pump the trolley up.
Yeah.
And once we get it to the right height, sir, we'll pop the side down, get you to pop your legs onto that stool.
All right. Let me just check this again. Remind me of your name and date of birth.
David John Hughes, 26/10/45.
Any questions?
No.
Good. So what we'll do is pop the little needle in your hand, for starters, then we'll sit you up, do the injection in your back, lie you back down, and then it'll be send off to sleep.
Right, okay.
Right, I'm just going to go and get all cleaned up especially for it. It'll take a minute or two, you just relax, and that'll be the position we need you to adopt in a minute or two.
Right.
And then we protect his eyes.
One of the reflexes he loses when he's asleep is the ability to blink if his eyes are stimulated by something coming up to hit them. So they lose their corneal reflex. So what we're going to do is tape his eyes shut for that reason, and also they don't lubricate their eyes when they're asleep.
So this chap's now anaesthetised, ready for his surgery. He's got the tube into his lungs to keep him breathing. He's got this tube into his stomach to deflate it and make the stomach be out the way for the surgeons. His eyes are protected. We've put an epidural in. He's got this monitoring, which allows us to monitor his fluid status more closely. He's got the basic monitoring, blood pressure, ECG, and pulse oximeter. In addition to all that, he's got a big cannula where we'll attach our fluids. He's got an arterial line. He's got a temperature probe to monitor his temperature throughout the case. And he's also got a urinary catheter, so we can monitor his urine output. And now we're ready to go through. These are just antibiotics for the case.
What we will do is in a moment we're going to cover him with a bear hugger, which is a mattress which blows warm air over him, because obviously he's had an anaesthetic, so he'll be vasodilated, which lets you lose heat. So what we're going to do is cover him with a big mattress that blows warm air over him like a hairdryer, and we'll show you his temperature recording when we start.
The tools we use for laparoscopic surgery include a camera which goes down a 10mm laparoscopic port, and then we usually have 2 or 3 other instrument ports which are either 5 or 10mm in diameter, and the combination of these allows us to move the tissues around and dissect the tissues with as much versatility as we would have in open surgery, if not more.
We've been in theatre for about 40 minutes now. Patient stable, asleep. These are the monitors which show his heart rate of 73, his blood pressure is nice and stable at 88. This is in part due to his epidural, which will predict that will give him good pain relief afterwards. His temperature's a little bit low, but we're actively warming him up. And this monitor we can use this to ensure that he gets the adequate amount of fluid, so that afterwards he's not reliant on intravenous fluids, but can take fluids by the mouth as all part of an enhanced recovery programme. All finished now, all right? We chose an epidural, so that meant he avoided the need for morphine. And morphine is, one of the main causes of patients feeling sick in recovery.
David? David, you're just waking up in recovery. Operation's all finished. Alright, take some nice deep breaths for us. It's all finished now.
From the surgical side of things, had no pain. He was moving both his legs, so we had a good localised epidural block. He didn't complain of any sickness, probably largely because we'd been able to avoid using the morphine-like drugs.
All we're doing at the moment is just helping to support David's airway just until he's woken up a little bit more. It seems quite vicious, but it's not. It's just to bring the jaw forward and make sure that his airway's okay. Once patients start to wake up a bit more, they will automatically open their eyes and start to fight you, and we'll let go, and the patient will take over their own airway. But obviously, whilst they're in here, we'll keep a very close eye on them. And then after that, we'll make sure that David's pain relief's okay and check where the block of the epidural is lying to make sure he's kept comfortable. And then when we're happy, we'll take him through to the high dependency unit.
Largely because of David's epidural, we organised for him to go to high dependency afterwards. He stayed in the high dependency for 24 hours, which for laparoscopic surgery with an epidural is generally sufficient. Pain wouldn't be so much of an issue after 24 hours, and then he would be then managed with simple painkillers, which can be done effectively on the ward. So people go to high dependency for different reasons. For him, it was purely because he had an epidural where they can look after it more closely. Other people may go there because of their other medical problems they have. And David went back off to the ward within a day.
From a post-operative point of view, after the patient has gone home, we usually follow them up with a telephone call a few days subsequently. We'll then bring them up to our clinic to make sure they're in good health and they're happy with the outcome.
Well, I have to go back and see the surgeon and the designated nurse, and they will discuss my future with how many times or whatever. But they have indicated that I will have regular blood tests. But I don't have to go to hospital for that. I can have it done at the doctor's. I've got a card, and if I need help, I've just got to ring this number and I'll speak to the designated nurse for any help or assistance.
I'd had sort of pains in my left side on and off for a few years really, and they became almost normal. I just saw it as the way I was and tried to manage it myself. And then I went to the GP a couple of times, and I think they thought maybe it's a bit of irritable bowel or whatever. But then I went back again about a year ago, well, maybe a bit longer than that now, and I was really in quite a lot of pain. I felt really unwell and had a temperature. And she said, the GP said she thought it might be small diverticular, so she referred me to the hospital. And I was told that that diseased part needed to be removed and resected.
Patty had diverticulitis, and she had a particular variant or complication of that, such that there was extensive scarring and narrowing of the bowel, and that was proving very uncomfortable for her, and the only way forward really for her was to have the diseased section of the bowel removed and the ends joined together. I need to complete a consent form to get you to look at that.
I saw Mr. Gore before the pre-assessment, and he explained to me all about the operation that I'd need. And I let him know that following an orthopaedic operation I'd had several years before in another hospital where lots of things had gone wrong, but I was really quite anxious about further surgery. And he was really understanding. He gave me a copy of a report from his department the previous year of the surgical outcomes for patients. And I really appreciated his openness with this, because it showed that not only were the outcomes very good, but it also spoke of a strong commitment to patient care and safety, and that was just what I needed to hear. It was very, very reassuring, so that was great.
I would hope to do this as a keyhole operation. We make sure that the patient is very well counselled about the underlying condition and the nature of the treatment planned. So when they come up to the pre-assessment clinic, we're able to have a conversation that is specifically about the day-to-day of what to expect during the time of their operation, and also to talk about the technical details of the operation, so that they can give properly informed consent at that time.
Okay, Patty, so this is your pre-assessment. Pre-assessment is a time for the patient, really. It's also a time for us to assess the patient and make sure that they're fit enough, A, for surgery, for the anaesthetic, and that they understand exactly what's happening to them.
The pre-op assessment, I mean, I found that so reassuring, I have to say. I mean, Gemma, the specialist nurse, was wonderful.
So if you get stuck, you can give me a ring and just say, Gemma, I don't know what's happening. Right. And we can talk about it over the phone. It's fine. All right.
She answered all my questions.
What we're planning on doing is called a left hemicolectomy.
I had a diagram to show exactly what they're going to do. And I felt really listened to.
This bowel doesn't really have a great job. Okay, you've got 17 metres of small intestine. That does all the hard work for us. This just stores.
And it was very helpful to me to know that I could phone Gemma between then and when I came into hospital with any queries that I might have forgotten, anything I wanted to ask. So that was great for me to know that. The day of the operation, I was sort of up at the crack of dawn, as one would expect, because we had to be there quite early, and took the 2 drinks, had a shower and took the 2 drinks. And I was as ready as I'd ever be, I think. I did feel well prepared, as for the day. The theatre staff were wonderful, they really were. They reassured me, they were professional, but it was really, really friendly. And I went into theatre feeling really held.
Hello. How are you? My name's Tom.
And in very safe hands, which was just what I needed to hear, which was great.
Can I have a look at your wristband to begin with, please?
Which one then?
If you could tell me your name and date of birth.
Patricia Price.
Come as low as you can. Yeah. Yeah. I've got that, dear. I've got that.
When you're ready, you can come down so we can have you down. You hold up to that.
Is it on the trolley, Charlotte?
Patient ID confirmed, consent signed, site correct. Allergies unidentified. Surgeon to confirm, any difficulties?
No.
Procedure? Any blood loss expected?
There's some 500 minutes.
And appropriate DVT programs given.
The use of laparoscopic techniques allows us to dissect the tissues around the bowel with at least as much versatility as we would have had open surgery, if not more. Brilliant. Okay. We use a variety of energy sources which are specifically designed to cut and seal tissues with the minimum of bleeding. So we do aim for bloodless surgery these days. These instruments will necessarily produce a plume or an aerosol. It looks like smoke, but it's actually vaporized water, really.
Just sit down.
You right there, Patty? You're just waking up in recovery, it's all finished.
And I have to say, when I woke up after the operation, it was just brilliant not to have any pain. I hadn't experienced that before, and I was really quite alert, so that was great. The next thing I woke up, remember waking up on the ward about 3 o'clock in the afternoon. The third day, that was the Sunday, I was feeling remarkably better. I was really able to walk around, do most things. I was, feeling much better. I was still quite tired, but, much better than the previous 2 days. I felt on the Monday morning when I went home, and Mr. Gore came and discharged me, I felt really ready to go home and looking forward to go home. I really did feel, I was amazed how well I felt after such a big operation, after, just 4 days. So that was pretty good. What's so brilliant for me is the pain that I'd had in my side for so long. I had it sort of almost daily, and it'd become normal. I'd forgotten what it's like not to have it. It's all gone. All the, everything seemed to be working well. I mean, my energy levels are returning.
Cheerio, Margaret, all the best for you.
My life's returning to normal, but as I say, to wake up every morning, I would have that pain and it's gone. That's fabulous. I just feel now I can get on with my life, which is lovely.
The video you have just watched featured typical examples of colorectal surgery procedures when the process goes well. Your experience may differ, but at all times you will be given and should expect the best possible care.